Good morning. I'm Martin Green and I'm the Chief Executive of Care England, and I also have the great honour of being the Chair of the International Longevity Centre UK. Welcome to this session, which is going to look at the issue of whether or not COVID-19 has had an impact on health inequalities between generations. We're delighted to welcome as our presenter Professor Sir Michael Marmot. Sir Michael is the Director of UCL's Institute for Health Equality, and he has also been a Professor of Epidemiology at University College since 1985. He has been the author of many publications and is also currently an advisor to the Director General of the World Health Organization. So we're extremely privileged to have somebody of global significance talking to us about this really pertinent issue of health inequalities. Sir Michael.
Thank you. I will talk about the UK, but first I want to put the pandemic in global perspective. The United Nations Development Programme produces a human development report each year, and they produced a special report for this year around COVID. If you look at the global burden of disease, daily deaths, stylized, here's transport injuries, HIV/AIDS, self-harm, and malaria. And there's COVID-19. Absolutely dramatic. And that's the first wave. And we know in many countries there's a dramatic rise with a second wave. The Human Development Report uses a Human Development Index, which has three components: life expectancy, education, and gross national income per person, adjusted for purchasing power. And this is the global Human Development Index. From 1990, you see it was increasing every year, some years a bit slower, some years a bit more rapidly. There's the global financial crisis. It increased a bit more slowly after the global financial crisis. And then 2020, the effect of COVID-19. So its effects globally are absolutely dramatic. I want to talk about a hurricane for a moment. This was Hurricane Maria in Puerto Rico, and deaths that occurred in the 2 months after Hurricane Maria. The lowest socioeconomic group, the medium socioeconomic group, and the highest socioeconomic group. Any huge external shock, like a hurricane, and indeed like a pandemic, reveals this. I've been saying from the beginning of the COVID-19 pandemic that it will expose the underlying inequalities in society and amplify them. The opening lines of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. We hear a lot, rightly so, about the NHS at the time of a pandemic and otherwise, but I want to talk about the conditions that made people sick. Going back in history, I chaired the WHO Commission on Social Determinants of Health. We reported in 2008, and then I was asked by the British government, can we apply the findings and recommendations of your global commission to one country, England? And in 2010, with my colleagues at what became the Institute of Health Equity, we produced the Marmot Review, Fair Society, Healthy Lives. And in February this year, before the pandemic crashed upon us, we looked back at what had happened in the last 10 years. And my summary was, we've lost a decade, and it shows. Why? If you look at life expectancy at birth, it had been increasing about 1 year every 4 years for women and for men. And in 2010-11, that rate of increase slowed dramatically. What happened in 2010? Well, we had a new government. They're a bit sensitive to the idea that a government could have led to a slowdown in health improvement. Is that possible? Well, as I'll show you, yeah, it is possible. A second feature of our health picture is the inequalities, the social gradient. This is people classified by where they live, which in turn is classified by degree of deprivation. Most deprived, least deprived, deciles. And indeed, the poorest do have shorter life expectancy than everybody else. But inequalities are not confined to that. It's a gradient all the way from bottom to top. The gap between the least deprived and the most deprived in life expectancy was 9.5 years for men, 7.7 years for women. And that gap has been getting bigger. The gradient's been getting steeper over the last 10 years. And if we look by region, if you're in the least deprived 10%, relatively rich, it doesn't much matter which region of the country you live in. Life expectancy was improving a bit. This is women. If you're in the most deprived 10%, there are huge regional differences. It matters a great deal which region you live in. Life expectancy was improving for women in London, but going down for women in the bottom 10% in every other region outside London. So 3 pictures of health in England before the pandemic in February this year. Slowdown in improvement in life expectancy, increase in inequalities, and life expectancy for women and to some extent for men in the poorest areas outside London was getting worse. And it's not just life expectancy, but healthy life expectancy. The bottom is disability-free life expectancy. You see the gradient is steeper for disability-free life expectancy than it is for life expectancy. So it's not just length of life, but healthy life. And this line, if 68 becomes the state pension age, you can see that nearly 3/4 of the population do not have disability-free life expectancy as long as 68. And years in poor health have actually been going up. Males, 15.8, 16.1, 16.2, females, 18.7 to 19.4. This is a miserable picture. Now, when we come to the life expectancy, people who are trying to defend it said, well, it's got to slow down sometime. Life expectancy can't keep improving forever. Maybe we'd reach peak life expectancy. So we looked at other countries. This is annual life expectancy improvement in weeks, 2011 to 2017. And in all of these countries, life expectancy was improving more rapidly than in the UK. Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, Austria, Japan, Czech. There we are. UK had the slowest improvement of any of the rich countries except Iceland and the US. No, we had not reached peak life expectancy. The slowdown in the UK was more marked than in every other European country except Iceland. And of the big countries, only the US looked worse. Then came the pandemic, and we look at excess deaths. As you know, there are international differences in the way cause of death is assigned. So excess deaths doesn't confine itself to looking only at those death certificates that mention COVID-19. You predict how many deaths there will be in each week of 2020 based on the rates of the previous 5 years. Then you observe how many there were in effect. And the difference between the observed and the predicted is the excess. And the excess in England was greater than in Scotland and was greater than in any other European country. The US has been an utter disaster in its failure to manage the pandemic, and the excess mortality in England is higher than in the US. If the US has been an utter disaster, what does that say about us? I've been saying for some time that the health of a population tells us a great deal about how well that society is functioning. And if health had not improved over 10 years, that means society had not improved over 10 years. And if inequalities had got bigger, that means inequalities in society had got bigger. And perhaps it's all of a piece. Our failure to have health improve in line with other rich countries over the previous decade and our mismanagement of the pandemic perhaps are markers of a dysfunctional society. And when we look at the inequalities, we see a very similar picture. Gray is the all deaths, the inequalities in all deaths by decile of deprivation. You see the gradient I just showed you. And the blue are COVID-19 deaths. And the gradient's very similar, which means the causes of inequalities in COVID-19 are rather similar to the causes of inequalities in health more generally. There is some excess here at the bottom, which we think is linked to exposure in frontline occupations and to living in overcrowded, perhaps multi-generational households. And there's Scotland, very similar picture, the social gradient in all causes, the social gradient in COVID-19. When we look at Black, Asian, and minority ethnic groups, we see this strikingly higher mortality for COVID-19. This is Black women compared to white, 2.5 times. When adjusting for deprivation and other things, about 2/3 of that excess can be attributed to deprivation. When ONS published these figures, I was on BBC Radio. The health minister had said he was very concerned about this and people should practice social distancing and wash their hands. And I was asked, what do you think? And I said, good advice. And we should deal with structural racism. Yeah, but what should we do tomorrow? Tomorrow, we should deal with structural racism. So you see Bangladeshi or Pakistani, most of it is linked to deprivation. And in later figures, up to July, controlling for geography, where people live, other measures of socioeconomic characteristics. Interestingly, although many of us, myself included, thought that pre-existing health conditions would play a role. In fact, for the excess of Black African and Black Caribbean, pre-existing health conditions played very little role in that excess. It was very largely due to where people live, geography, and the kind of work that they did. With Bangladeshi and Pakistani, pre-existing health conditions do seem to play something of a role in the excess. So if the causes of COVID-19 are similar to the causes of health inequalities more generally, of inequalities in COVID-19, this is what we identified back in 2010 in the Marmot Review, Fair Society, Healthy Lives, as the causes and where we should intervene to reduce inequalities. Give every child the best start in life, education and lifelong learning, fair employment and good work for all. Number 4 was really radical. In a rich society, everyone should have at least the minimum income necessary for a healthy life. healthy and sustainable places and communities, and taking a social determinants approach to prevention. Well, what happened? The government that was elected in 2010 had as an ambition a rolling back of the state. And they achieved that ambition. In 2009-10, 42% of GDP went in public expenditure. And that came down year after year. So by 2018-19, it was 35%. We were in the middle of the European range at the beginning of the decade, and we were towards the bottom of the European range at the end. And those cuts in public expenditure were done in a most regressive way. Total local authority spending per person, the dark grey, by level of deprivation of the local authority. So this is the least deprived 20%. And local authority spending went down by 16% per person. And the more deprived the area, the greater the reduction. So in the most deprived quintile, local authority spending went down by 32%. Look at spending on adult social care, went down by 3% in the least deprived areas and went down by 16% in the most deprived. The greater the deprivation, the greater the need, the greater the need, the greater the reduction in spending. Could such a regressive approach to public expenditure play a role in the miserable health picture that I described? Yeah, I think it could. You wanted me to talk about generations. Let's look at child poverty. Pre-housing costs, 18% of children were in poverty, where poverty is defined as 60% median income. After housing costs are taken into account, it's 27%. And that 27% in 2010-11 went up to 30% in 2017-18. What about lockdown and education? Yep, when the schools shut, it had a big impact on inequalities. Teachers were asked how far behind their pupils were. Teachers in the least deprived schools said 3% of their pupils were not behind at all, 24% were 1 month behind, 32% were 2 months behind. Teachers in the most deprived schools said 11% of their pupils were 6 months or more behind, 18% 5 months, 24% 4 months. So there's a spreading out, an increase in the educational divide. Let me go back to the global picture. Countries divided by level of human development, low, medium, high, and very high. Before COVID-19 school closures, the effective out-of-school rate for primary education age children was just under 27%. Then came COVID-19, and that went up to 86%. Under 7%, 74%. In every region, there was a rise in the effective out-of-school rate for primary school age children. So globally, in 1970, about 28% of primary school age children were effectively out of school. And this is what had been happening globally. Wow, that's terrific. By 2019, more than 90% of primary school age children were in school. The blue is what's happening with the pandemic, a sharp rise. The red is what would happen were there no internet access. And the black is if you could equalize internet access within a human development group. And that would just about reverse the rise in the effective out-of-school rate. Now come back to the UK. Had we managed to get equitable access to the internet and to computers, we might have done a great deal to reduce that increase in the educational divide? Let me speculate. I said that I thought that our miserable handling of the pandemic was of a piece with a slowdown in life expectancy, and said something about how well our society was functioning. There's a group that published a social progress index, and I compared 3 countries: Germany, which handled the pandemic well, the USA and Brazil, which handled it very badly. So on inclusiveness, Germany and the USA looked rather similar in 2011. Germany remained high. The USA declined, particularly after 2016, and Brazil similarly. Personal safety, Germany stays high. The US, sharp decline, probably beginning on the 20th of January 2017. Much lower than Germany, and Brazil much lower. So this is not even correlation, let alone causation. It's speculation. It's speculation that a measure of social progress means the society is functioning well or not well. And that tells us something about how well we manage the pandemic. That radical publication, the New York Times, said, our society is constructed to reward the rich in good times and punish the poor in bad times. And I think that's what's going on. On the 15th of December, we will publish Build Back Fairer, the COVID-19 Marmot Review. So we're going to relook at my 2020 report from February in the light of the pandemic and containment. And let me finish with this. A well-being approach can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. Where might I have got such a quote? Amartya Sen, philosopher and Nobel Prize-winning economist? Possibly. But no, it came from the New Zealand Treasury, the Ministry of Finance, in 2019. I would like us to do this as we think about building back better, or as I would put it, building back fairer. Let's put not economic growth at the heart of what we're trying to achieve, but well-being of the population, which can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them.
Thank you very much, Sir Michael. That was a very thought-provoking presentation. And I think it really showed that there have been impacts of COVID, but there are also underlying issues that have been there a long time. And in dark times like this, they get magnified. So I think our challenge is to make sure that as a society, we look at the levers we can pull in terms of policy to make those inequalities reduced and to give people a fairer access, not only to health, but to lifestyle and life chances. So thank you very much for that presentation, which was really thought-provoking and excellent. Thank you, everybody, for listening to this session. There is a short break now, and then sessions will begin again at 11 o'clock. So thank you all for your attendance.